Good morning. Uh, I will request Dr. Kamaljeet Singh sir, Dr. Agini, Dr. Santosh to come on dais, please. Dr. Kamaljeet Singh sir, Dr. Santosh Bhide, Dr. Agini. Now this is the okay, one photograph. Okay. Thank you. Thank you very much for good photograph. Thank you. Thank you very much. Uh, so the Santosh and Kamaljeet Singh sir. So this is the uh, SICS class, and in this the what I am going to speak. मेरा presentation शुरू करो. Hello. Take it to the computer. Okay. Okay. Thank you very much. Now we are in the era of the FECO, and from the FECO we are going for the you can say the FEMTO, and now from FEMTO also we are going some new lasers. But this is if you see today also the SICS, yes, SICS remains one of the choice of the cataract surgery. And if you see the happenings in India, we operate near about 70 lakhs cases every year, and out of that the 46 lakhs patients are operated by SICS till date. It means the maximum number, more than 55% cataract is performed by the SICS surgery. Now this is the there is no any financial interest in my presentation. Here you can see the comparison of the surgical induced astigmatism in various incision in the manual cataract surgery. So this is the you can see here, whenever you see the internal incision is very important, because the nucleus is large one, and so engagement of the nucleus in SICS is more important, and for that the internal incision should be larger than the external incision. Now the internal incision always more than 7, 8 to 10 millimeter opening inside the eye, and then you can see the it is in the pocket 1.5 millimeter pockets on both sides. So that reduces the 3 millimeter incision, and then by the curvature, so that is 2.5 millimeter, it is a curvature, and so actual incision remains is 5 or 5.5 millimeter in the center. So that causes the astigmatism. So whenever we are thinking on this, so incision should be funnel shaped, not a tunnel shaped. So outside it is a small 5.5, inside it is a 7 to 10 millimeter incision inside the opening. So opening inside should be larger than the opening outside, because here only one thing important in the incision, that engagement of the nucleus. If nucleus is not engaged, it doesn't come out, and so then we struggle for the removal of the nucleus. So those who are the SICS surgeons are doing SICS, whenever they are constructing the tunnel, in that the external opening can be 4 millimeter, 5 millimeter, 5.5 millimeter, and then the other where you are extending, it should be 4 millimeter. It means 1.5 pockets and 2.5 is a curvature. So by that you can go ahead, so that the internal opening is more and this is very important whenever you are doing SICS. Now see the SICS incision, see here the conjunctiva, you must cut the conjunctiva properly, and another thing is you must repose the conjunctiva. Otherwise patient will get irritation. See here what I am doing is see this is a modified Frown incision learned from Blumenthal. See here on both the sides there is a back cuts, so that the nucleus is also had the breadth, not only the thickness is also there. Now see the pockets are made. So it is a 1.5 millimeter pockets on both the sides. Here you will see the pockets are made on both the sides. So these two pockets are very, very important. And now the side port I am making here. I always do with the Blumenthal technique. So this is the another side port I make for that. See here. So whenever the incision is taken, it should be slightly away from the blackish zone, that is the limbal portion in the sclera. Again the extension on the both the sides, see here the extension on both the side, and once this is extended, then again you will see the pockets. So it should be in one plane. If there are racks in between, the nucleus will not come out. So plane is also important whenever the tunnel is dissected. So in the same plane you will dissect, and if there is a, you can say plane is different, the nucleus will not come out, and we will feel that why nucleus is not coming out. So here you will see the side ports as I am doing the, you can say this Blumenthal technique. So I require two side ports, and see now the extension. Whenever you go in, you cut. If you cut while coming back, then what happens? Then there will be a V-shaped racks. So there is no a straight, or you can say the you can say parallel to the limbus incision inside. The inside opening will be different than the outside. So whenever you are going in, you cut. Whenever you are coming out, don't cut. So that is very, very important whenever you are doing it. Now the principles. So why I have shown this? Because to know the principles, and principles are see here the principle is the astigmatism. Astigmatism is directly proportional to the cube of the length. It means if your length is more, then the astigmatism, if it is a 1 millimeter length is more, you will get 3 diopter of the astigmatism. It means cube of the length, and the inversely proportional to the distance from the limbus. If you go away from the limbus, then that will reduce. If you go 2 millimeter away, 3 millimeter, how much millimeter you can go away? You can't go away more than 2 millimeter or 2.5 millimeter. So beyond that, if you will go, then the nucleus will be inside the tunnel, that will not come out. So maximum you can go behind is only 2 millimeter. You can't go behind more than 2.5 millimeter. So there is a limitation. But for the horizontal incision, there is no limitation. But sometimes we see the incision extends more than 6 millimeter. There the astigmatism is much more. So to how to approximate the calculation base, this is a rough astigmatism base is here. The roughly if you calculate, if it is 4 millimeter incision outside, excluding the, you can say the on the both side, if you make the pockets, excluding that 4 millimeter straight incision, there is a 1 diopter of the astigmatism is seen. Then the, you continue, then the 6 millimeter, then the 3.3, it means near about 4 millimeter astigmatism is there. And if it is a 8 millimeter incision, then there is a 8 diopter. What I was telling you, it is a directly proportional to the cube of the length of the incision. So external incision is very, very important, where you can take a curvilinear incision and pockets, that will help you. So that is there in this. And see astigmatism here, we will see the astigmatism in straight and frown incision. Straight incision and frown incision, why we always say that it should be frown? Because as compared to these two, in our study we found that the frown incision had significantly better. It means the mean net astigmatism as the compared with the straight incision. This has also been concluded in the study of Singer. These results suggest that use of frown incision minimizes the or induced astigmatism, surgically induced astigmatism in the frown incision is reduced. And so if you compare the position, if you go for the superior, it induces the against rule, then the lead pressure effect is there, near visual axis, it is near the visual axis, also induces the more astigmatism. But if you go to the supratemporal or temporal, induces the with the rule astigmatism, no pressure effects, away from the visual axis, induces the less astigmatism. Now, preoperative workup is very, very important. Whenever you are doing for the phaco, why not for the SICS? SICS is also a cataract surgery. So, we are applying all the investigations for the phaco and we are not applying the investigations for the SICS. No, you must do the autokeratometry, you should go for the optical biometer, also you should go for the topography. So, that is what is we are doing in the only we are thinking the provides the steep and flat axis. Everything we are doing for the premium lenses, but for us every patient is a premium, and that may be SICS patient or that may be non-SICS patient. So, all the investigation we should do whenever we are doing it for the cataract surgery. Now, here again the previous glasses you must see what are the previous glasses he is using. Then the current refraction, if possible, if it is a immature cataract, you can go for the refraction. Then the abrometry, you can also see the astigmatism in that. See here, you can see the TK1 and TK2, it is 43 and 45. Whenever you know the astigmatism is there and what is in the axis, then you can change your plan of the incision. And if you change the plan of the incision, as you know, astigmatism is surgically induced astigmatism in 4 millimeter incision is 1. If it is 6, it is 3.4. So, 3.7. It means that if you induce that in the quadrant where you want to reduce, so in that it is always better to go for the choose the position. Now, see here, you have seen the astigmatism, and here now what I am doing is I am going in the quadrant where I can correct the astigmatism which is there, which is not possible in phaco, because in phaco our incision is 2.2 millimeter or 2.8 millimeter. Here our incision is 5.5 millimeter or 5 millimeter, and that will correct the astigmatism without any other thing. So, before if you know the astigmatism, accordingly you can take the incision and then you can reduce the astigmatism. So, this is what you can see when you calculate pre-op, then pre-op only you can decide how to go ahead and how to reduce the astigmatism. Now, here you will see again what I am doing is here whenever you are doing any surgery, see here this is Dr. Agini who is doing a left-handed surgeon, see here. So, whenever we are doing the surgery here, always remember that the conjunctiva, we will have to repose the conjunctiva. So, instead of making very small conjunctival flap, you can make a large conjunctival flap and repose that. If you repose it from second day, patient will not feel any, you can say foreign body sensation or no watering. So, the conjunctiva is also equally important whenever you are doing the phacoemulsification, this SICS, because in phaco you are not, and see now, whenever you are going in, you should go minimum 1 millimeter inside the cornea. If you are not going inside the cornea, then that tunnel is not good tunnel, or it is not a self-sealing. And now see here, everything is done, and after that I am showing you how much millimeter. It is a 4.5 millimeter tunnel from where the nucleus is removed. And you know, if it is a 4.5, astigmatism is 1 diopter. So, you can reduce the astigmatism whenever you are properly constructing the tunnel. So, take home message here is learn the technique to construct the tunnel first, because see, in phaco, as a phaco is very important, but here the tunnel is very important, because everything is going to come from the tunnel. Plan the location of the incision, know your own surgical induced astigmatism, use the available technology, whatever technology in your hand, use it properly, so that the outcome of the patient on second day are good. Thank you very much. Now, I will call upon Dr. Agini. Parex,
yes. Thank you so much, sir. So Dr. Kamaljeet and Dr. Santosh Bide are not here. I would request Dr. Rakesh Bhai Shakya to please come on the dais. Is Dr. Namrata Shri there? I would like to invite her also on the dais so there can be a good discussion. Thank you so much, sir. So the incision is very, very important. It is the gateway to the entry of a very good SICS or of a very good surgery. So, sir, thank you for teaching us the incision. Thank you, Dr. Rakesh Bhai.
Now Dr.